Seven.
Mag-cue sa akin kung go na. Ano? In ba?
I miss record lang po tayo.
Hello, good morning, everybody. Welcome to the PES session on business opportunities and unmet needs for financial coverage and care among elderly Filipinos. I'm Joseph Capuno, professor at the UP School of Economics and now with NEDA. For today, we'll have three speakers and three papers that will talk about issues and concerns confronting elderly Filipinos and some of the government initiatives that have been in place to address those concerns. So I'm looking forward to a very lively and informative session this morning. But before we formally begin, let me say some of the house rules for this session. So we'll provide each speaker 15 to 20 minutes for their presentations, and we keep all Q&A portion towards the end of the session. If you have burning questions, please type them in the chat box, and we'll try to read all of them and address them towards the end of the session. So without much further ado, I'd like to give you the first presenter, and she is Dr. Grace T. Cruz, who is currently the director of the University of the Philippines Population Institute and vice chairperson of the Demographic Research and Development Foundation Incorporated. Her main research interests are technical demography, mortality, and aging of the population. She headed two large-scale national surveys of older Filipinos. Currently, she is a project investigator of the longitudinal study of aging and health in the Philippines, which is part of the two-country comparative studies of the Philippines and Vietnam. Dr. Cruz holds an MA degree in demography and a PhD in sociology from the University of the Philippines. Prof. Grace, over to you.
Thank you very much, Dokoy, for that kind introduction. So, all right. So the title of our paper is Unmet Needs for Hypertension and Diabetes Care Among Older Filipinos. I'd like to acknowledge my co-authors, Maria Carlin Sharon Karabaraban, Mark Ryan Pagirigan, Aleli Kraft, Kailin Kaliglan, Joseph Capuno, who are all here present, and Dr. Yasuhiko Saito, who's joining us from Japan. So this is the outline of my presentation. I started the background with study, data and methods, results and discussions, summary, conclusions, and recommendations. So a little background, I'll talk about the aging in the Philippines since it's the context of our study. So the question is the Philippines an aging population? UN defines a population to be aging if at least 60% of its population are 60 years and 10% are 60 years and over. So this is the data from the various censuses from 1960 to 2020, showing us the increasing number of older persons over time and increasing proportion. So as of the last census in 2020, we have something like 9.2 Filipinos 6 years and over, comprising 8.5% of the total population. Projections show that it's going to breach the 10% mark between 2025 to 2030, at which time we will be considered an elderly society. So if you look at the growth rate of the population by sector, the older populations has been the fastest growing sector starting in the 1990s. It's a small population size, but growing the fastest. Just to give a perspective of how we stand vis-a-vis our Asian neighbors, the Philippines here in 2021 still a young population compared to, say, Singapore that has transitioned to an aging society starting 2005. And Japan, of course, which is the oldest age structure in the world, is considered in hyper-aging society, which is defined as those with at least 30% of their populations that are 60 years and over. So in the Philippines, results of our study show that hypertension and diabetes are among the leading diseases reported by older Filipinos. It's therefore of interest to find out to what extent appropriate care are provided for those at risk of these diseases. So our study objectives are as follows. Estimate the prevalence of unmet need for hypertension care among older Filipinos. Estimate the prevalence of unmet need for diabetes care among older Filipinos and evaluate the differentials of unmet need for hypertension and diabetes care across socioeconomic, socio-demographic, health, and economic factors. So data and methods. Our data is primarily sourced from our study, the 2018 Longitudinal Study on Aging and Health, or we call it LSAP. It's the first nationally representative study on aging with a panel design. So panel design meaning that we will have to follow our respondents over time. We were supposed to follow them up in 2020, but we were overtaken by the pandemic. So we hope to go back to the field this year. Okay. LSAP is actually the third nationally representative study on older persons in the country, but it's the first to have a panel design. And the study is implemented by the Demographic Research and Development Foundation with funding from the Economic Research Institute for ASEAN and East Asia or area. LSAP has the following objectives. First of all, to investigate the health status and well-being of the Filipino older people and their correlates. And as soon as we have the follow-up study, we will be able to assess the determinants of health status and transitions in health, which you cannot do with cross-sectional data. So the sample baseline data is a size of almost 6,000 respondents, 60 years and over living in community dwellings, which means we did not include those who are institutions. Response rate was quite high at 94%. Our design oversampled those in their 70s and 80s to ensure that we will have enough sample to follow up in the wave 2. And it's a multi-stage sampling design with provinces as the primary sampling unit, barangay as a secondary sampling unit, and older persons as the ultimate sampling unit. It is also multi-actor, which means we did not only interview the older persons, but at least one of the caregivers and an adult child of the older person. So the instruments at baseline were at least 5, but in the follow-ups going to increase to 1 more to 6. So in baseline, we had this household questionnaire, main questionnaire for the older person, for the caregiver, adult child, and the anthropometric questionnaire. The anthropometric questionnaire is where we gathered information for performance tests, including height, weight, waist, circumference, arm length, number of teeth, blood pressure, which we are going to use in this study, pulse, grip, strength, muscle mass, using the bioelectric impedance analysis. So as I've said in the follow-up, we're going to add 1 more questionnaire, the verbal autopsy and mortality questionnaire, because we want to collect information of respondents who died in between the baseline and the follow-up survey. For our study now, we define hypertension based on the classification provided by the Joint National Committee on Prevention, Detection, Evaluation, and Treatment of High Blood Pressure, which defines hypertension as those with systolic more than 140 and a diastolic of more than 90. This is the categorization of our unmet need for hypertension care. It is in accordance with the care cascade method that identifies unmet need according to the domains of diagnosis, treatment, and control. So we identified older persons with unmet need for hypertension care as those lost across the continuum of care. So we asked them a direct question whether they were diagnosed by a doctor. So if they said they are diagnosed, then they are classified as in this box diagnosed. But if they said they were not or they don't know, we added the data on their blood pressure. And if their blood pressure test reveals that they are hypertensive, then they are considered undiagnosed hypertensives. Among the diagnosed, we asked about treatment. Those who are untreated are considered untreated with unmet need for treatment. And among those who are treated, we further ask whether it's controlled or not based on the blood pressure that we found out during the survey, day of the survey. So these are the categorization of unmet need: undiagnosed, untreated, and treated, but controlled. And these are the operational definitions. Of course, the rest of them would be those without unmet need for hypertension. So these are just the specific questions that derived all these categories with the corresponding number of analytical cases from the sample. Okay, so the same thing is done for diabetes, except that we did not have a test for sugar level at the time of the study. So our analysis will just be limited to treatment, so that those who said that they have been diagnosed with diabetes but are not being treated at the time of survey are considered untreated and therefore categorized with unmet need for diabetes care. Okay, and these are the specific questions to gather those information. These are the variables for the multivariate analysis. Explanatory variables include age, sex, marital status, and living arrangement. We tried to combine these two with married and living with children as a reference category. Education, we classified them as elementary, below and below, high school, college, urban, rural residents. We look at a functional difficulty measured by ADLs. If they experience any one of those ADL difficulty, body mass index, smoking, unmet needs for health, wealth quintile, recipients of 4Ps or CCT, or if they're recipients of remittances from children or any member of the family. For statistical analysis, we use weighted percentages. We look at multinomial logistic regression, assess the factors associated with unmet need for hypertension care, and we applied multiple classification analysis to compute for predicted probabilities. For unmet need for diabetes, we use binomial logistic regression, and all analyses were weighted and adjusted for complex sampling design. So what are the results of the study? So the first is just a table showing distribution of the two samples, because the analytical sample for the both hypertension and diabetes are quite different, and the sizes are also very different. So, okay, what is the prevalence of unmet need for hypertension care? Our results show that only 39% have no unmet need for hypertension care. So the majority, or 61%, have unmet needs. This is divided into 26.4% who are undiagnosed hypertension. The second highest is uncontrolled hypertension at 22%, and the lowest is untreated hypertension at 12.6%. And this is the result of the multinomial regression analysis and we highlighted here the factors that are significantly associated with each of the outcomes for unmet need. And we see, for instance, that age here is significantly associated with uncontrolled hypertension, along with place of residence, particularly in rural areas. For untreated hypertension, it's married and living with others. That is comes out significant, along with college education. For health factors, smoking as well as BMI come out significant as associated with undiagnosed hypertension. whereas ADLs, functional health, and BMI are significant for uncontrolled hypertension. For the economic variables, it's the wealth quintile, particularly the richest quintile that is associated with the treatment, and the same, no, middle and richer categories that are associated with uncontrolled. So to have a better appreciation of the direction and the levels of the result, we computed for the MCA for the predicted probabilities and converted them into proportions for easy interpretation. So looking at uncontrolled hypertension care, we see that one of the factor, age, is a significant factor, and we see here the age gradient with increasing proportion of uncontrolled hypertension care need increasing with advancing age. This is the differential for urban and rural areas, with significantly more of urban residents having uncontrolled hypertension care relative to their rural counterparts. This is for uncontrolled hypertension still. This is functional health. So that older persons who say that they have at least one ADL difficulty exhibited stronger or higher proportion with uncontrolled hypertension care compared to those who have no reported functional difficulty. This is untreated hypertension care. And one of the factors that are significant there is the living arrangement and marital status. And we find out that those who are unmarried, including those who are already widowed, but currently living with their children, exhibited the lowest proportion with untreated hypertension care. And this is followed closely by those who are married but living with children. So those who are living with their children seem to exhibit the lowest proportion of uncontrolled hypertension care, whereas those who are married but living with others, here 18% has the highest proportion who said that they have untreated hypertension care. Still untreated hypertension care, another significant factor there is education. And you see here a very strong education gradient, with those in the lowest rung of the educational ladder exhibiting the highest proportion with untreated hypertension care, while those in the college, the lowest. And this is smoking, with the regular smokers having higher proportion of undiagnosed hypertension compared to non-smokers. So this is the result for undiagnosed and uncontrolled, but here we show all the categories for BMI because it's significant for two outcome variables. And we see here that for undiagnosed, which is the light blue here, there is a significant difference across categories of the BMI, and uncontrolled, which is the dark blue here, is also significant across the categories of BMI, with the obese, for instance, exhibiting 41% who have undiagnosed or uncontrolled hypertension. 30% among those with overweight have uncontrolled hypertension, and those who are underweight exhibited the lowest uncontrolled hypertension at 9. The next factor that has a significant effect on untreated and uncontrolled is wealth quintile. And one of the significant factors here is uncontrolled. So we see here the significant differential across the categories of the wealth quintile. So that 28 and 29 also closes the middle. So the top three here show very high level of uncontrolled. So belonging to the highest level of the wealth quintile is associated here with higher levels of uncontrolled hypertension. And untreated is this green, untreated. So, but it's the richest which have lowest proportion of untreated. And it's the poorest who have the highest proportion who said they have untreated hypertension care. So that's as far as hypertension is concerned. So we move to diabetes treatment, where we see that 34%, so it's a lower proportion, have been diagnosed but not receiving any treatment. And if you look at the results of the binary logistic regression, it's only one factor that's significant. This is the functional health, so that those who have at least one ADL difficulty have higher likelihood of experiencing unmet need for diabetes care. All the other factors did not come out significant. So as a way of summary, our study shows that there's a high level of unmet need for hypertension care and diabetes care in the Philippines. The LSAP findings indicate at least 61% of hypertension and 34% of diabetes unmet need for unmet need. No? And the gaps are evident in the diagnosis, treatment, and control. This table provides the summary of the findings on the factors associated with unmet need for hypertension and diabetes care. And our findings show that the correlates of unmet need for hypertension care vary across outcomes, including undiagnosed, untreated, uncontrolled hypertension care. In particular, those who smoke regularly have the higher risk of undiagnosed hypertension care. Those with normal BMI show the highest proportion with undiagnosed hypertension care. Older persons who are married and living with others, including their spouse, are most at risk of untreated hypertension. As expected, those with college education and those who belong to the richest quintile report the lowest probability of untreated hypertension. For uncontrolled hypertension care, the oldest age group, that's 70 years and over, those living in urban areas have at least one ADL difficulty. Those who are overweight or obese and belong to the higher wealth quintile demonstrate greater risk of uncontrolled hypertension care. Our analysis showed that the youngest cohort, married, living with their children, highest education with no ADL difficulty, those who are underweight and belong to the richest quintile are more likely to have no unmet need for hypertension care. Sex does not come out significant in any of our analysis. And only functional health exhibit a significant correlation with unmet need for diabetes. So as a concluding note, we see that correlates for unmet need for hypertension care vary across outcomes, including undiagnosed, untreated, and uncontrolled, and only functional health, which is ADL difficulty, is strongly associated with unmet need for diabetic care. So our findings underscore the need for targeted policy and program interventions that address the management and control of hypertension and diabetes in the older population. So thank you very much to UP EPANU Foundation Incorporated. Would like to thank also AREA who funded the project. And this is the project report for our baseline study in case you're interested. Thank you very much and have a good day.
Thank you very much, Professor Grace, for nearly older Filipino like me. I had a lot of takeaways from your presentation. One of them is that perhaps give up my dream of being among the richest. Otherwise, I'll have a lot of control that hypertension in the process. Let's move on to the next center, and she is Dr. Aleli Kraft, who's the department chair of the University of the Philippines School of Economics and a board member of the UPCon Foundation. She's also a member of the Health Technology Assessment Council of the Department of Health. He has done numerous studies in health economics and is currently a principal investigator of the ongoing project of UPCon that implemented the Nueva Ecija cardiovascular risk experiment, which is a survey that aims to understand how beliefs about cardiovascular diseases affect demand for preventive care and to assess the effectiveness of government programs in delivering primary prevention of CVDs. She holds an MA degree in economics and a PhD in economics from the University of the Philippines. Aleli, over to you.
Thank you, Popoy, for that very generous introduction. Good morning. We'd like to present our study on missed opportunities for hypertension diagnosis among the elderly in the Philippines. And this is many creators. Our UPCON R4 studies team, which includes Tokoy and Kaylee done here, and also Dr. Owen O'Donnell. And the LSAP study team who have graciously allowed us to use the LSAP data, and we are collaborating on finalizing and writing and finalizing this paper. So I'm going to proceed using this very simple outlines. I'm going to give a background, then what we are trying to find out, and then the methods. Well, I'm very glad that Dr. Cruz has already given us a very brief background on the LSAP, which is also the data we're going to be using. But I'll spend a little bit of time in defining our variables and the estimation methods and correlates. And then I'll give you the results, as far as the prevalence of hypertension, a variable which we call missed opportunity and potential diagnosis. And then I'm going to look at the correlates of these variables, followed by discussion and summary. Okay, so the main reason why we're here is because we recognize that cardiovascular diseases are still the leading causes of death in the Philippines. So I reproduce here a table from the International Health Metrics and evaluation, a country profile of the Philippines in 2020. And they track the leading causes of death from 2009 to 2019. So the first two, which are ischemic heart disease and stroke, are still there. And moreover, we also see an increase in diabetes and hypertensive heart disease. So the rank was elevated from 2009 to 2019. So this is still ongoing. Of course, after the pandemic, we don't know what has happened, but I would suspect that these are still leading causes of disease. All right, so it's understandable that CVDs have not gone down, because the risk factors have not gone down as well. So CVD deaths have not decreased, as CVD risk factors are still prevalent, especially among the elderly. I was informed that elderly is no longer the right term, but older persons. Okay, so in the 2018 National Nutrition Survey, it shows that among the elderly, 35% have hypertension. So as they were measured, in the NNS. And I think the NNS also measured their FBS, or their blood sugar. So it's 13.8% have high fasting blood glucose, and also the LSAP data show that only 46% and 13% of older Filipinos were diagnosed by a doctor to have high blood pressure and diabetes respectively. So in those cases, there are probably people who have risk factors, but as Dr. Grace has mentioned, they are undiagnosed, untreated, and moreover, they are controlled. So the risk factors are still there. And we see also from the figure on the right, again from the International Health Metrics and Evaluation, that the risk factors are still prevalent. So we see that from 2009 to 2019, high blood pressure actually increased. As far as the ranking of the risk factors, now number 2 from number 4. The smoking also remains, or in fact, it increased as a risk factor. But we also see that high fasting plasma glucose, which is your sugar, has been maintained, also body mass index. Okay, so the risk factors for CVDs are still prevalent, and therefore, of course, our diseases, CVDs are still prevalent among our population. But then we have a set of actually cost-effective interventions that have been simulated, like smoking reduction, smoking cessation, weight management, and taking of hypertensives and statins. And these have been recommended. These have been shown to be cost-effective, and they are actually included in this protocol called the WHO-EM. So this is the WHO Essential Package of Primary Healthcare Interventions that is for low resource set. So this includes CVD risk screening, counseling, and prescription of medicines for adults who are in clinics. But what has happened is that the primary prevention of CVD risk factors in low and middle income countries rely on opportunistic screening at health clinics. So that means your adults only get screened when they present themselves at the clinic. So we don't have like a nationwide active profiling or screening of adults. So they would get screened if they get to the clinic. So they're not actively sought out by your healthcare workers for screening. But there's evidence that going to public health clinics increases exposure to these primary prevention efforts. So in our project, we conducted a randomized experiment in Nueva Ecija, and we found that based on some aggregate outcome, a combination of measurement, diagnosis, and medication of risk factors as well as medical advice. Okay, so with that aggregate outcome, we saw that people that those who went to clinics are exposed to this. So in a sense, no, if they go to the clinic, then they would get screened, they would get measured, and they would get diagnosed. Albeit, of course, when we looked at the more further outcomes like blood pressure control, weight reduction, smoking cessation, it takes more than one visit to the clinic. But at least, no, when they visit the clinic, we get at least advice, diagnosis, and some medication of the risk factors. So we wanted to look at that further, no, to validate that, no, by looking at the older population. So we asked the question of whether visits of the elderly to health clinics increase exposure to screening and diagnosis of hypertension, of course, which is a CVD risk factors. And we look at what factors affect whether the elderly get diagnosed or not. And as we use the data from the LSAP, so nationwide data. So this is really in contrast with our Nueva Ecija study, which is just for a particular province, but this time we use the LSAP data. And the difference is that here the LSAP data focuses on the older persons, 60 and above, whereas our study was for the 40 years old up to 70. So, and we look at high blood pressure, aside from the fact that it's available. High blood pressure is a significant risk factor, as we have shown, for heart attacks and strokes. And the elderly are at higher risk of developing complications, and of course, dying from this condition. So if we are able to diagnose and actually treat the hypertensives among the elderly, then we could prevent deaths and also improve the quality of life of those who are actually surviving. So I won't really focus too much on the LSAP because Dr. Cruz has already given us a very good description. After all, they're the ones who conducted this data. But we are using data from 3 out of the 5 questionnaires. So this would be the household questionnaire because we looked at the wealth, no, the social demographic information, and the main questionnaire for the older person, and the anthropometric questionnaire because we also used the measurements for blood pressure. So we define these variables that we use, no? So the same way we measure hypertensive, so those with measured systolic blood pressure greater than 140 milligrams mercury, or diastolic blood pressure greater than 90. And those who report diagnosis of hypertension. Sometimes you would get a normal blood pressure reading, but you already are getting treated. So you're actually already a hypertensive. It's just that maybe you have controlled blood pressure. So this is included in the definition of hypertensives. And then we use the average of the last 2 readings, no, for hypertension. And that would mean that there are some samples, there's some individuals who are not included in sample because they don't have at least 2 blood pressure readings. No? And then we define those who are diagnosed as those who have reported to have been told that they were hypertensive. So there's a question in the questionnaire, no? Have you been told by a doctor that you have high blood pressure? So we use that to indicate that they have been diagnosed. And then we have a variable called missed opportunities. So this variable takes on a value of 1 if those who have undiagnosed hypertension, no, as measured, reported to have visited an outpatient health facility in the last 12 months. No? So in the sense we're saying, okay, we're measuring them, no, they have high blood pressure, but they were actually visited a facility in the last 12 months. And then we break that down further by asking what facility they visited. So we can break it down to having had a missed opportunity when they visited a public facility, and missed opportunity when they visited a private facility. So among the public health facilities included, are barangay health stations, rural health units, hospitals, district hospitals, provincial and city hospitals, and of course your public national hospitals or public specialty hospitals. While for the private, these include, of course, private clinics and private hospitals. Okay, and then we have a variable called potential diagnosis, which is just a sum, no, of those who have high blood pressure and are diagnosed, and those who visited a clinic and was not diagnosed. So this potentially would tell you the true, in a sense, the true prevalence of your diagnosed hypertension. Okay. So we just constructed a probit model on the likelihood to have a missed opportunity in general, and a missed opportunity when you visit public facilities, and a missed opportunity in private facilities. We did also estimate equations for your diagnosis and potential diagnosis, but I will focus on the missed opportunity variable for now. For our correlates, we have our wealth quintiles, of course, education, age, sex, the place of residence, living arrangements, which we had like what Dr. Grace has mentioned, whether they're living with their spouse or living with their children, their current employment status, because some older persons are still very active, they're working, and of course, our health insurance coverage. So this is, in a sense, a picture of our variables. No, so among the hypertensives, by the way, the N are unweighted, but when we look at the portions, these will now be weighted. So out So we have diagnosed and undiagnosed, and among those undiagnosed, we break it down to those who visited the health facility and those who did not visit. And we further break down this number to those who visited the public health facility and the private health facility. Okay, so these are our results, no? So this table tells us in a way the prevalence, no, of adults with hypertension diagnosed based on our analytical sample and the missed opportunities for diagnosis as a percent of the total hypertensive. So we see that those among the hypertensives as defined, about 65% are diagnosed, no? And the rest, of course, are undiagnosed. Of the undiagnosed, about 11.1% had visited the health facility in the last 12 months. So they are labeled as missed opportunities because they could have been diagnosed on those visits, but they were not. Okay. And if we look further, about 7% are missed when they visited public facilities, and about 4% were missed when they visited private health facilities. And so when we talk about potential diagnosis, we can sum this about 64.6% plus 11.1%. So the potentially diagnosed would be about 76%. Okay. Now, so and we can see some variations as well, no, for your according to your socio-demographic variables. So we see, for instance, that just laser pointer here. So those with college degrees and higher have higher likelihood of missed opportunities as well as those with elementary. This segment of your older population, no, the 65 to 69 age group. So I would term this as your nearly retired. If you think about it, no, they were just nearly retired, so they probably were they lost some of their benefits, no. So they would have here, no, the highest proportion of missed opportunities, no. We also have higher missed opportunities in urban areas, and I think here the living arrangement, they also consistent, no. Those who living with children, that's really strange because you think that they would their children would be actually taking care of them, but it's probably they taking care of their children
Or grandchildren.
or grandchildren. So yeah, that's true. Okay. So what happens is that we see a lot of variations emerging in the prevalence of missed opportunities when the type of facility visited is considered. So in general, the prevalence of missed opportunities is higher in public facilities compared with private facilities. And this pattern is consistent across all of the correlates, no? And so and this is validated when we look at the average marginal effects of the likelihood of having a missed opportunity for diagnosis. So here we present figures. So these are the whisker plots of the marginal effects, no, of our equation. So across all the correlates. So this is for your overall missed opportunity. This is missed opportunity in the public and missed opportunity in the private. So without considering the type of outpatient of clinic visited, those in the middle wealth quintile here, okay, are less likely to have a missed opportunity for diagnosis compared to the richest wealth quintile. So our reference category is your richest wealth quintile. So for these two So the richest would have less likelihood of having a missed opportunity for diagnosis. Okay, so there are no significant differences with respect to education. Okay, but then we see that here, no, the younger, older persons, older persons, those who are between 60 to 64 are less likely to have a missed opportunity when they go to the clinic. Okay. Those residing in urban areas are more likely to not be diagnosed, so they're more likely to have a missed opportunity when they visit clinics. And the same is true for those who are working. So we see that this is significantly different from the base category. Okay. So, but then we see differences in the likelihood of having missed opportunities when we look at the type of facility visited. So among those who visited public facilities, no, an older person belonging to the richer quintile would have a lower likelihood to have a missed opportunity, meaning that they would be diagnosed when they visit a public facility. Okay. While not significant, there are positive marginal effects for the bottom two wealth quintiles. Here, no, it's not significant, but it's positive, meaning when the poorest visit public facilities, they're more likely not to be diagnosed. And that's really strange because the WHO Open is actually being implemented in public health clinics. Okay, so but we see here when they do visit private clinics, no, the poor are less likely to have a missed opportunity, meaning they will more likely be diagnosed, no, when they visit a private health facility. Okay, so these are just differences, and across the age groups as well. No, we see for your when they visit private health facilities, no, those who are 60 to 64. 70 to 74 and 75 to 79 are less likely to have a missed opportunity. Okay. So our study, of course, there are some other findings, but I'm not going to go into them in greater detail, no. But there are certain limitations, no, of our study. One is that we measured the blood pressure during the interview and not during their visit to the facility. So it's likely that during their visit, their blood pressure could have been normal, but when the survey was done, their blood pressure was actually quite high. Okay. The other thing is that when they diagnose blood pressure, clinically they would say, okay, you come for maybe 2 or 3 days and we measure your blood pressure. So it's a series of readings, no? So as per clinical recommendations. But the blood pressure that we measured was just on the day itself, no, on the survey itself. And of course, the recall period of the survey is quite long, 12 months, no? So baka may nalimutan na rin ng mga older persons. So as far as the details of the visit is concerned, halimbawa, they were told that they were hypertensive, but they had forgotten. So those are some of the limitations of our study. So just to summarize, the diagnosed hypertension prevalence will increase by up to 11.1 percentage points if those who visited health facilities were diagnosed when they visited. And this is more, there's more in public than in private facilities. So the poor who visited private health facilities are likely to have a missed opportunity than the poor who visited public facilities. So this is strange finding, so to speak, that we would like to highlight. Okay. So older individuals are less likely to have a missed opportunity when they visit private health facilities. Older meaning 70s, no, above. So when they visit private health facilities, they are actually diagnosed, no? And urban residents are more likely to have a missed opportunity. They visited a public facility. So of course, that facility would be also in that urban area. So what are some of the implications that we draw from these findings? One, I would try to hazard that there can be two directions to reduce missed opportunities. No? One is to strengthen implementation of PhilPen protocol, specifically in screening for CVD risk factors opportunistically and monitoring those who present themselves in public health clinics. So, nandun na sila eh. So why not do the diagnosis? Why not do the treatment? No, if they are diagnosed. So there has to. So in a sense, we're saying that there can be a better implementation of the PhilPen protocol in our public health clinics. We have not really delved into why they don't do it. Probably they're too busy. They don't have the. There should be drugs because they are the drugs are available through the diabetes and hypertension clubs, no? So there's really no reason not to do this screening, especially since they're older persons. So parang dapat trigger na yun. These are more at-risk persons. And then the other is that it seems like the private sector is actually doing better, no? We were already controlling for the social, so as much as possible, we would encourage participation of private clinics in the PhilHealth primary benefit package and encourage utilization of elderly in these clinics. The PhilHealth primary benefit package supposedly follows also the PhilPen protocol in that they would have screening and diagnosis. And if the private clinics go participate, then they would also, I think, be eligible to receive the hypertension and diabetes drugs. So by including them there, and that's where the poor seem to be better, not really better treated, or at least diagnosed. No, then that could really reduce, hopefully, the undiagnosed hypertension among the elderly. So that's it. Thank you very much. And acknowledging also the funding provided by the UPCON R4D project and ELSAP, ERIA and DRDF for allowing us to use the data. Thank you.
Thank you, Aleli. As you have seen the two papers, of course, they derive from the same data set. Tells us that the health needs and of the elderly cannot be, shall we say, limited to one certain group of people. The unmet need for hypertension and diabetes care cuts across within people with different living arrangements, ages, and location, and wealthy types as well. Yeah? And in terms of missed opportunities, we've also found interesting correlations across different socioeconomic and demographic groups. So we cannot really pinpoint any particular group. This is, more likely to have a met need or missed opportunity than other groups. The characteristics are shared across demographics. So perhaps a public health intervention here would be, should we say, universal in that respect, so that we don't miss on anybody. And so it's rather opportune that our third speaker will talk about two public health interventions and social protection intervention that specifically target all elderly Filipinos. So that will be the subject of the next presentation by Benedict Jr. Evangelista, who's a PhD candidate here in the UP School of Economics, where he also earned his bachelor's and master's degrees in economics. His research interests encompass topics in health economics, household economics, and macroeconomics. He was also formerly one of our research associate in the UPCon Health Lab. So Junjun, if you're ready, over to you.
Okay. Thank you, sir, for that introduction. Sorry, I just want to test. Can everyone hear me? In the yes, okay. Okay, so so let's start. Good morning, everyone. So given that the prior presentations discussed unmet needs and missed opportunities for healthcare of elderly Filipinos, or older Filipinos, sorry, we now proceed to potential policies expected actually to help them. So the title of this study is Awareness and Utilization of PhilHealth and Senior Citizen Benefits of Older Filipinos. I am co-authoring this study with Kayleen Calicdan, Dr. Aleli Kraft, Dr. Joseph Capuno, and Dr. Owen O'Donnell from Luzon. So for our outline, we first give a brief background of the central focus of our study, which are the benefits entitled to senior citizens related to healthcare, as well as our study objectives. Next, we actually present our methods in answering our research questions. Then we will present some preliminary results in our study, followed by a summary and some policy implications as well. So as a brief introduction, senior citizens in the Philippines are entitled to benefits, especially on healthcare. So a good source of these benefits are senior citizen benefits stated in RA 9994 or the Expanded Senior Citizens Act of 2010. This actually details that senior citizens can receive discounts on medicines, professional fees or physician fees, and medical and dental services. However, to avail of these services, a senior citizen must present an identification card issued by the local office of senior citizen affairs. Now, another privilege given to senior citizens is health insurance coverage from the National Health Insurance Program. For this study, we identify two ways on how the elderly are covered by the National Health Insurance Program. One is by being a lifetime member, where a lifetime member is defined as a PhilHealth member who has reached retirement age and made at least 120 monthly contributions. And the other one is through mandatory coverage of all senior citizens, granted by RA 10645 or the 2014 amendment to RA 9994. So this amendment allowed an expansion of the mandatory coverage across previously uninsured senior citizens. So later, we will explain how we identify lifetime from mandatory members for our study. So now, given these concepts and benefits, we seek to study if there are differences between coverage by law, supposedly 100%, and effective coverage, that is, those who are aware and are utilizing these benefits. We realize that gaps between nominal and effective coverage and even awareness and utilization exist. For example, as stated earlier, a senior citizen ID is not automatically acquired since it requires a senior citizen to undergo registration procedures. Likewise, even if RA 10645 grants PhilHealth coverage to all senior citizens, they may not be aware of its benefits, or if they are, don't actually use them in times of need. We also consider that they might be also a gap between the two types of PhilHealth coverage, lifetime and mandatory coverage. So we aim to achieve the following. First is to estimate rates of coverage awareness and benefits utilization between the two types of PhilHealth membership and senior citizen ID registration status. Second, to explore if a lifetime membership and a senior citizen ID holder have an effect on coverage awareness, usage of PhilHealth benefits, and discounts on top of PhilHealth benefits. Last is to find out if having knowledge of PhilHealth coverage affects inpatient care use. So as a first step to motivating our study, we found a number of studies tackling coverage, awareness, and utilization of PhilHealth in the Philippines for elderly. So the first study by Abrigo et al. Finds that insurance coverage increased by 16 percentage points from the 2014 reform made by RA 10645. This led to an increased household per capita out-of-pocket health expenditures, and they attribute this to an outward shift in demand for medical care. Sionko et al. Finds that inequalities in NHIP coverage and outpatient care utilization across wealth quintiles decreased over time, and eventually near equality was actually reached in 2017. For inpatient care, however, they found that utilization shifted from the pro-rich to the pro-poor. In addition, we also found two smaller scale studies. Cablao et al. Finds that in Nueva Ecija, there is very high awareness of general coverage by PhilHealth, and awareness on discounts, government assistance, and other benefits are also quite high as well. Salenga et al. Finds that there are high rates of awareness on medicine discounts, but this is lowest for those with only elementary education and no schooling. However, only 50% of them used medicine discounts, and this is even lower for those with elementary education and no schooling. So next, we also turn to the international literature to find how insurance membership could affect utilization of healthcare for elderly or in general. So in general, there's sort of like quite like a mixed evidence on how insurance membership affects healthcare utilization. So some studies like Acharya et al. In Nepal finds that insurance membership isn't really a significant correlate, while other studies actually, like for example, Van der Wielen et al. In Ghana, finds that insurance membership increases healthcare utilization. Now, the last three studies here show that there are factors other than insurance membership which can actually affect utilization and awareness of insurance and even use of healthcare, like membership cards, social networks, and even awareness meetings. Now, proceeding to our methodology. So the prior two studies also used LSAP 2018, and also the first presenter, Dr. Cruz, has already given us a brief background of what the LSAP 2018 encapsulates. So in particular, we use information from two of their current 5 questionnaires. So one is an household questionnaire, which informs us on demographic and economic information on household members. And then the main questionnaire for older person respondents gives details on socioeconomic and demographic characteristics, health status, services of elderly, cognitive assessment, health utilization, and much more. Now, circling back to our definitions of PhilHealth membership, so we distinguish lifetime from mandatory members based on available information from the data using work history and pensioner status. So we worked on an assumption that pensioners were able to make the mandated 120 monthly pension contributions prior to retirement and thus able to also make the same number of monthly contributions to PhilHealth, thus qualifying them for a lifetime membership. So we use two definitions to define a lifetime member. First, if a respondent receives pension and has worked previously. And then the second one is that if the respondent's spouse receives pension, the respondent is deemed a lifetime member due to being a dependent, regardless if they receive or don't receive pensions. Likewise, we use two definitions to define a mandatory member. So if neither the respondent nor their spouse receives pension, they are deemed as mandatory members. And if the respondent is a pensioner but has reported to have never worked previously, then they are also considered as mandatory members. So for a much better understanding of our classification, we present this distribution mapping here. Okay, so from there, we now proceed to defining senior citizen registration. So we identify those who are senior citizen ID holders as those who answered yes to the question when asked if they are a registered senior citizen or if they have a senior citizen ID. So for our outcome variables, our study focused on 3 outcomes. So first is on awareness of coverage, which means that he is aware or that the respondent is aware if they reported to have a PhilHealth membership. Use of PhilHealth benefits means that the respondent reported the use of PhilHealth benefits during hospitalization, whether as a member or as a dependent. And top-up use of senior citizen benefits means that given their usage of PhilHealth benefits, the respondent reported to also having availed of senior citizen discounts on their medical expenses upon confinement. Now, the main method of analysis that we use is a logistic regression aside from the cross-tabulations that we will also present later. So our main independent variables are having a lifetime membership, being a senior citizen ID holder, and then the interaction of both. So we execute these three models for each outcome variable, each containing different and accrued adjustments on the following correlates here to also check for the robustness of estimates. Okay. So we now proceed to the results. So here we actually see that the distributions, here we first present the distribution of awareness and utilization by PhilHealth membership type. So here we see that there were more mandatory PhilHealth members than lifetime members. Lifetime members have a higher awareness of their PhilHealth and health insurance coverage compared to mandatory members. However, utilization rates of PhilHealth benefits during confinement of the two membership types do not differ significantly, and the same can be actually said about top-up utilization rates. Next, we go to the distribution by registration status. So first, we find that registration rates of senior citizens are quite high at around 89%. Awareness rates of health insurance and PhilHealth among senior citizen ID holders are above 80%, and majority of registered seniors availed both PhilHealth and senior citizen discount benefits. Next, we now proceed to our regression results. So here, we see that we find lifetime membership increases the likelihood that one is more aware of their PhilHealth coverage by around 5.9 percentage points than if they are a mandatory member. Registered seniors are more aware of their coverage by around 14.5 percentage points than non-registered or non-senior citizen ID holders. Now, in the second panel, well, we find that neither being a lifetime member nor being a registered senior leads to being more likely to use PhilHealth benefits. Having a senior citizen ID increases the probability of using discounts on top of PhilHealth benefits by 21 percentage points. Next, to further enrich our analysis, we also performed supplemental regressions using different outcome variables and compared them to our main findings. So specifically, we compare the following. So awareness of health insurance versus on PhilHealth membership, usage of PhilHealth benefits on the use of senior citizen discounts in general, and usage of senior citizen discounts in general compared to usage of these discounts as a top-up. Also, we report the result of our analysis on inpatient utilization, where we used the aforementioned models before, but modified them to account for potential effect of awareness in PhilHealth and health insurance coverage. So first, we see in comparing health awareness of health insurance versus awareness of PhilHealth membership, we see that there are similar results across registration and lifetime membership. So the effect of a lifetime membership is more or less the same, but the registration as a senior citizen affects awareness on health insurance by just a slightly lower estimate at around 12.4 percentage points. On the usage of PhilHealth benefits compared to usage of senior citizen discounts, we see that lifetime membership still here is not significant, where they do not use either PhilHealth benefits or senior citizen discounts significantly different than mandatory members. While we see here that registered seniors are 19.2 percentage points more likely to use their privilege to reduce their expenses. Here, we still find similar results for the effects of both PhilHealth membership and senior citizen ID ownership on utilizing the senior citizen discount in general or on its top-up. Now going to our inpatient regression, we see here that senior citizen registration contributes positively as well to the probability of inpatient care use. While lifetime membership is still insignificant in this case, knowledge of PhilHealth or even health insurance increases the probability by around 4 to 5 percentage points. Now, to summarize, lifetime members we saw earlier are more aware of their PhilHealth coverage than mandatory members. However, lifetime membership does not have a significant effect on utilization of PhilHealth benefits and inpatient care. Senior citizen ID holders, on the other hand, compared to non-ID holders, tend to be more aware and more likely to use their senior citizen discount benefits. Awareness of PhilHealth coverage and owning a senior citizen ID contributes to use of inpatient care. However, we still see that there is no significant difference between types of membership in inpatient care use. Now to our policy implications, we see that these two programs are actually important in crafting policies towards assisting healthcare for the elderly. So we saw that senior citizen registration is a beneficial tool in providing healthcare benefits to the elderly, since it actually raises awareness on health benefits, leading them to a higher likelihood of availing care aside from availing their senior citizen discounts. So upon registration, a senior citizen becomes aware of such benefits, leading them to use care and availing of these benefits. Second, we see that there is no significant differences in the use of PhilHealth benefits across membership types, despite lifetime members being more aware of their coverage. This, however, can imply that provisions of RA 10645 contributing towards universal healthcare are actually realized, as mandatorily covered members are also able to avail of benefits and care as lifetime members. To conclude our study, we also identify ways that our analysis can be proved for this topic. So, first is on the classification of lifetime and mandatory membership by the provision of direct information on membership type. Second, it would actually be beneficial to examine amounts of received benefits from PhilHealth between membership types. Third is to actually include outpatient care if data is available, and also examine if there are differences in patterns of use between public and private facilities. And last is to also use a health status index to control for some potential endogeneities among the health status correlates and also the other correlates included in the regressions. Lastly, of course, we would also like to acknowledge the support provided by the Demographic Research and Development Foundation, the Economic Research Institute for ASEAN and East Asia, the UPCON Foundation, and the Swiss National Science Foundation. Thank you, and that's all.
Thank you, Junjun. Now, something to look forward to when I reach 60 years old. I'll get my senior citizen card, although I may not be able to reach my dream of being the richest quintile. Now, we open the session to the Q&A part. Do we have a question in the chat box? Yeah.
Are the participants allowed to post Q&A? Yeah. So participants are allowed to post.
Do we have questions from the online participants or the panelists? Yung mga estudyante daw namin na nandyan sa
Recitations.
this is time to impress your teachers. Should be listening. In no particular order, may I call on? Dr. Saito daw. Professor Grace. Dr. Saito. Are you online, Dr. Saito?
And Job Avalon.
Grace pakinggan mo yung sino nakakita?
Dr. Saito, are you raising your hand?
And Joffrey Avalos also.
Mr. Avalos, are you raising your hand?
Estudyante ko ah.
It's Christine. Christine, make our day. Christine and Gloria.
That's 5 points.
Christine? Wala,
Sorry.
nahihiya.
Well,
Yeah.
Si Sir, Dr. Saito is now given.
Okay.
Okay, please, Dr. Saito, you have the floor.
I think I can speak, but well, thank you very much for inviting us to the session, and yeah, this presentation is very interesting. Although the survey we conducted, we don't have really lots of information on monetary, variables, and so the use of the pocket money for paying for the inpatient and outpatient, those information we don't have. So the I'm sure that the those who are interested in the economic side of the these unmet need to analyze, I'm sure it could have been very difficult to deal with. Well, because the survey is very very long, and we have 5 questionnaires, and so, but if we have a chance that we may add some monetary term for this medical expenditure or healthcare expenditures in the future. And what do you think that the Professor Cruz?
Yes, Saito. Tanong ko na.
You can speak.
We need to include
We have almost completed the questionnaire, so we'll see. It might be difficult to add at this point.
All right. But so I want to ask that the 2 presenters that the if we have that kind of economic aspect of the monetary side of the information, is that your analysis is going to be better, or you could give better policy implications or the recommendation?
You'd like to answer?
For the missed opportunities, for that particular paper, the monetary aspect will not be very crucial, although we would want to assess whether they do have to pay for outpatient visits in the private sector. Because when they do visit the public sector, it's assumed that they have very nominal or very limited fees. The other reason why they probably didn't have a diagnosis is because the facilities, they might have been referred to laboratories outside the public sector, because the public sector doesn't have, let's say, the testing facility for blood glucose, or I'm sure they have for blood pressure. But that's also something, no? There could be some financial constraints that they face. That's why the diagnosis is not performed. On the other hand, if they do visit the private facility because they pay, the fee could actually also include the the laboratory tests or the diagnosis, and therefore as we see, they're less likely to actually have a missed opportunity when they visit the private sector. So that information would be helpful, because of course, if they visit the private sector and they do pay, then there's an incentive for the private sector providers to actually give them more services, because they're actually paying for those services as well. So that's something that could provide more nuance to actually explain why they have a less likelihood to have a missed opportunity when they visit the private sector, private facility.
Junjun?
So certainly, of course. I mean, especially for our topic, since we're dealing with, discounts and such, I think a monetary section would be extremely beneficial as well. Like for example, in the two literatures that I actually stated in the Philippines, like Sionco and also Abrigo et al., they actually use, I think they use mainly the demographic health surveys, which also I think details outpatient, inpatient, and also overall health expenditures, and also out of patient. So definitely, I think that we would also benefit from that. Also, since I kind of earlier made the point on the amounts actually possibly subsidized, or like um amounts like possibly covered by PhilHealth. So other than monetary information on maybe later waves of the LSAP, we would also maybe possibly actually compare some using data from PhilHealth as well. So yes, I think in our case, monetary information is also quite essential as well. Yeah.
Thank you, Junjun. Dr. Saito?
Yes, well, thank you very much for your input. And yes, yeah, if we can, I mean, we may consider adding those monetary terms, but for the person who is running the survey may not want to increase the number of questions. So
Maybe 6 questionnaires.
Yeah, they have 6.
Actually, I think that's not already been done. So it could be a further topic that can be explored. Dr. Cruz informed me that there is indeed a question that tells us how did you pay for your inpatient. So at least we can see, even if the proportion is not there as to what is out of pocket, but we can probably still say that at least just get the sense of they're still paying out of pocket, even if they're already using their field health and their senior citizen
right.
discounts. It's just that we cannot really say how much the out of pocket payment is, but at least we can say that it's not enough. These things because they still have to pay from out of their pocket. Yeah.
So in the Philippines, if you visit the clinic, well, and do they measure like blood pressure automatically? Is that correct?
It should be standard protocol that they do your vitals, so blood pressure, temperature. But usually when you go to the clinic, they just ask you about your particular complaint. So it's possible that it's not the blood pressure they're complaining about, but something else. And so they would tend to address that particular complaint rather than do a whole examination.
Right. But my point is that if the when the patient visits the clinic, as a standard procedure, all the patient be measured the blood pressure, then that will be I think it's a very cheap kind of preventive method of the having hypertension for all the adults, or not just all the adults. I mean the adult population that may prevent or make the awareness the hypertension among the population. Is that a good recommendation to make?
I agree totally that that is something that can be emphasized. That, you know, if an older person comes to the clinic, it's automatic that you really do a full-scale screening, not just for hypertension, but also for your blood sugar.
Right.
Okay, we have a question typed in the chat box addressed to Dr. Cruz, if I may read the question. Thank you very much for all the wonderful presentations this morning. You're welcome. Quick comment question, please, for Dr. Cruz. Research clearly acknowledges the role of spirituality for older patients' well-being. I'm wondering if religion was considered as an explanatory variable in Dr. Cruz's study. There may not be much variation in religious affiliations in Filipinos, but could it be worth exploring? Thank you.
Yeah, thanks for that comment. I don't know, there's no name. So yeah, unfortunately, we didn't include it as one of the factors associated with these outcome variables that we are studying. But we agree with you that really religious activities are one of the major social activities that older persons are engaged in. So it's really a significant factor to consider. So maybe we can take a look as we are finalizing this paper anyway and see if it has an impact on the outcomes that we're looking at.
Thank you, Dr. Cruz. Now, a question from Dr. Abalos addressed to Dr. Kraft. May I please know the reason why only those with at least 2 blood pressure measurements were included in the analysis? Will the results change if you include those with only 1 BP measurement?
Okay, thank you for the question. We really just follow the standard that's usually used when measuring blood pressure. Usually, in studies, you would say the first measure might be too high because the patient is nervous or you know, yeah. And so we need the second measure so that they're probably a little bit more relaxed, and we just take the average of the 2. So I'm really not sure whether our results would change substantially if we include only 1 BP measurement. Of course, the sample size will increase, and that would probably increase the precision of the estimates. But I think the general directions might not change. But we'll try to see whether that is that would be a kind of robustness check of the equations, which we haven't done, but we'll probably try to do that. But usually the standard is to use really the average of the 2 blood pressure measurements in these kinds of studies.
Dr. Abalos actually made the previous study on the baseline study on hypertension. So I think he used all 3. So maybe you can take a look also, Geoff, if the values that Aleli and Group are getting from their paper is different from your estimates using all 3 on-chain measures of blood pressure.
Thank you. I think we have enough time for one more question. If anybody has anything to raise? From our students, you haven't earned your grade yet. It's the last 2 minutes. Yeah? The time is running very fast.
We have also students here.
Our students in the room.
Our co-authors.
Co-authors. Okay, well,
Wala na.
yeah. So with that, we'd like to close the session formally and thank our panelists and the research teams who made, and of course the logistics team who made this session possible, and I would say Well, I'm excited as well. Kasi marami tayong napuproduce na findings that are, I think, relevant for the government to consider and other public health authorities to consider. So thank you very much. Abangan ninyo, we might have another round of public presentations in the future. For now, we bid you adieu and have a good day. Thank you.
Thank you.
Thank you.
Bye, sir. Bye, ma'am.